Tonight we begin with a question that might sound simple at first, but trust me, the answer is going to haunt you for the rest of your evening. Could you survive just one single shift as an emergency room doctor? And I'm not talking about whether you could handle the medical school debt or the grueling residency or even the soul-crushing bureaucracy of modern healthcare, though we'll absolutely get to all of that nightmare fuel eventually. No, I'm talking about whether you, right now, with your current mental fortitude and emotional resilience, could make it through 12 consecutive hours in the chaos that is a level 1 trauma center on a Saturday night. Picture this. You're standing in a fluorescent-lit hallway that reeks of industrial cleaner, barely masking the underlying stench of human suffering, wearing scrubs that somehow cost more than your nicest outfit despite being made of what feels like recycled plastic bags. And you've got exactly 45 seconds before 3 different catastrophes simultaneously demand your immediate attention. Forget every medical drama you've ever seen on television. Forget the heroic doctors with perfect hair who always know exactly what to do. Forget the cases that wrap up neatly in 42 minutes with a touching moment of reflection. The reality is that you're about to witness things that will fundamentally alter your understanding of human fragility. You're going to smell combinations of bodily fluids you didn't know could exist simultaneously, and you're going to be forced to make life or death decisions with incomplete information while a patient's family screams at you because you're not working fast enough. Let's be brutally honest here. The modern emergency room is not a place designed for human thriving. It's a pressure cooker where the most vulnerable moments of people's lives intersect with a healthcare system that's perpetually understaffed, chronically underfunded, and structured in a way that seems almost deliberately designed to maximize physician burnout. You'll be juggling 20 patients at once, each with their own complex medical history that you need to absorb in seconds, each presenting symptoms that could be anything from a minor inconvenience to an imminent fatal condition, and you'll need to determine which is which while 3 nurses are pulling you in different directions. The hospital administrator is breathing down your neck about bed turnover rates, and somewhere in the background, someone is literally dying. The stakes couldn't be higher, the margin for error couldn't be smaller, and the resources you have to work with are perpetually inadequate. And here's the thing that really twists the knife. Unlike almost every other profession where mistakes might cost money or time or reputation, your mistakes in the emergency room cost lives, real human lives, complete with families and futures and dreams that end because you missed something or misdiagnosed something or simply didn't move fast enough. That weight, that crushing psychological burden of knowing that someone's continued existence depends entirely on you making the right call right now with limited information and unlimited pressure. That's what we're really talking about when we ask if you could last even one day in this environment. So buckle up, because we're about to take you through exactly what a single shift looks like. And I promise you, by the time we're done, you're going to have a very different perspective on that routine visit to the ER you made last year when you thought you might have broken your toe. If you'd like more stories like this one, please subscribe so you don't miss any new uploads. I'd also love to hear from you. Let me know in the comments where you're listening from and what time of day you're tuning in. Your shift starts at 7 in the morning, and already you're walking into a disaster zone that's been brewing since the night crew clocked in 12 hours ago. Because here's something they don't tell you about emergency medicine. The ER never actually closes, never hits reset, never gets a fresh start where everything is clean and organized and manageable. No. you're inheriting 23 patients from the overnight shift, and at least 6 of them are what's called boarding, which is hospital speak for people who've been admitted but can't actually go to their designated floor because there are no beds available. So they're just sitting in the ER, taking up space and resources while also still technically being your responsibility, even though they're not really ER patients anymore. The nurse giving you the handoff report is on hour 11 of her shift and looks like she's been through a war, which honestly isn't far from the truth. And she's rattling off patient information at a pace that assumes you're absorbing and processing everything instantly. Bed 3 is a 67-year-old male with chest pain. Cardiac enzymes are pending. EKG shows some nonspecific changes. He's been here since 3 a.m. and he's getting increasingly agitated about the wait. Bed 5 is a 22-year-old female with abdominal pain. Pregnancy test is negative. CT showed possible appendicitis, but surgery hasn't come down to evaluate yet, and that was 2 hours ago. Bed 7 is a homeless gentleman who's a frequent flyer, came in for altered mental status. Blood alcohol level was 320. He's sleeping it off, but he'll probably leave against medical advice as soon as he wakes up. And on it goes, patient after patient, each one a complex puzzle that you're expected to solve while simultaneously managing all the others. And this is before you've even seen a single new patient who's about to walk through those doors. The waiting room, which you can see through a small window at the nurse's station, is already packed with 30 people in various states of distress. And according to the triage nurse, at least 5 of them have been waiting for over 2 hours, which means they're going to be angry before you even introduce yourself. The computer system, which is supposed to make everything more efficient, takes approximately 45 seconds to load each patient's chart, assuming it doesn't crash entirely, which it does with disturbing regularity, usually at the exact moment when you desperately need to access critical information about allergies or previous medical history. Your workspace is a small desk in the middle of the nurse's station where you have about 2 feet of counter space that you're sharing with 4 other providers, and there's no privacy whatsoever, which means you'll be having serious conversations about terminal diagnoses and end-of-life care while 3 feet away someone is arguing about lunch orders and a patient in the hallway is shouting obscenities. The phone rings constantly, never stopping, different lines lighting up with calls from consulting physicians, primary care doctors trying to get updates on their patients, family members demanding information you legally can't give them over the phone, and labs calling with critical results that need immediate attention. And here's the beautiful irony. You went to medical school for 4 years, then did 3 to 4 years of residency, specifically in emergency medicine, accumulating somewhere in the range of $300,000 in student loan debt. Also, you could spend your actual working hours drowning in administrative tasks, documentation requirements, and bureaucratic nonsense that has absolutely nothing to do with actual medicine. The first patient you actually see is a 54-year-old construction worker who fell 12 feet off a ladder and landed on his left side. And he's being brought in by ambulance with the paramedics giving you the rundown as they wheel him through the door. His name is Michael. He's conscious and alert, complaining of severe left-sided rib pain and difficulty breathing. Blood pressure is elevated at 160/95. Heart rate is 110. Oxygen saturation is 92% on room air, which is concerning but not immediately life-threatening. And he's got visible bruising already blooming across his left chest wall. your brain immediately starts running through the differential diagnosis, which is medical speak for the list of things that could be wrong. Broken ribs are almost certain. But the real concern is what those broken ribs might have damaged, because a fall like that could have caused a pneumothorax, where air leaks into the chest cavity and collapses the lung, or a hemothorax where blood fills the chest cavity, or even worse, a tension pneumothorax where the pressure builds up and starts compressing the heart and major blood vessels, which will kill him in minutes if you don't catch it. You need to examine him, listen to his lung sounds, order a chest x-ray, probably a CT scan of his chest and abdomen, get lab work, including a complete blood count to see if he's bleeding internally. And you need to do all of this while simultaneously making sure his airway is secure, his breathing is adequate, and his circulation is stable, because this is trauma medicine. And you follow the ABCs: airway, breathing, circulation. But here's where reality starts diverging from what they taught you in medical school while you're trying to assess this potentially critical patient. You've got three other people trying to get your attention simultaneously. A nurse is asking you to sign off on discharge papers for a patient in bed, 12. Another nurse is telling you that the patient in bed 8 is complaining of chest pain and wants to be seen immediately, even though you literally just got here and haven't even finished with the trauma patient. The unit coordinator is waving a phone at you saying that radiology is on the line, asking about the order you placed for the patient in bed 5. And to top it all off, a family member has somehow gotten past the security desk and is now standing right behind you, demanding to know why her mother has been waiting for 3 hours. You've been in the building for exactly 12 minutes. You've got a potentially critical trauma patient who needs your full attention and expertise. But you're being pulled in 4 different directions by competing demands that all seem urgent in the moment. And this is the reality of emergency medicine. You're never just treating one patient. You're managing a complex system of multiple simultaneous crises while also dealing with all the administrative and interpersonal chaos that comes with it. So you make a split-second decision. You tell the nurse you'll sign the discharge papers in 5 minutes. You ask another nurse to get an EKG on the chest pain patient immediately, and you'll look at it as soon as you're done with the trauma. You ignore the phone call because radiology can wait, and you firmly but politely tell the family member that you'll speak with her as soon as you've stabilized your current patient, but right now someone's life is potentially in danger and she needs to step back. Is this the compassionate, empathetic approach they taught you in medical school? Absolutely not. Is it the only way to actually function in this environment? Unfortunately, yes. You examine Michael, the construction worker, and your hands are moving through the assessment with practiced efficiency, even while your mind is racing through possibilities and protocols. You palpate his chest wall and feel the distinct crepitus of broken ribs grinding against each other under your fingers, which makes him wince and cry out. But more concerning is that when you listen to his lungs with your stethoscope, the left side sounds distinctly diminished compared to the right, which could indicate a pneumothorax or could just be because he's not taking deep breaths due to the pain. His abdomen is soft and non-tender, which is good because it suggests there's no obvious internal bleeding in the abdominal cavity. But you know from experience that internal injuries can be sneaky, presenting hours later after the adrenaline wears off and the shock sets in. You're ordering the chest x-ray and CT scan, typing frantically into the computer system that's still loading at a glacial pace, when the patient suddenly starts getting more short of breath, his oxygen saturation dropping from 92 down to 88, and His skin is starting to take on a slightly dusky quality that every ER doctor learns to recognize as a sign that someone is not getting enough oxygen. Your clinical instincts, honed by years of training and countless patient encounters, are screaming that something is actively going wrong right now, and you need to figure out what it is before he decompensates completely. You listen to his lungs again, and now the left side is almost completely silent, no air movement at all, and his trachea, which should be midline in his neck, is deviated slightly to the right, and these two findings together paint a very clear and very terrifying picture. This is a tension pneumothorax, meaning air is leaking from his damaged lung into the chest cavity and it's accumulating under pressure, collapsing the lung completely and now starting to compress his heart and the major blood vessels, which means his blood pressure is about to crash and his heart is going to stop beating if you don't relieve this pressure immediately. There's no time to wait for the X-ray, no time to get confirmation from imaging, no time to consult with surgery or call for backup, because in about 60 seconds this patient is going to code and die right in front of you unless you do something right now. So you make the call. This needs a needle decompression, which is exactly what it sounds like. You're going to stick a large bore needle directly into his chest cavity to release the trapped air and relieve the pressure. You call for the equipment, and a nurse who's worked in the ER for 20 years immediately understands the urgency and has everything ready in seconds, because good ER nurses are worth their weight in gold. And this is one of those moments where you're profoundly grateful for experienced staff. You locate the second intercostal space in the midclavicular line, which is medical jargon for the spot between the second and third ribs along the collarbone. You prep the site with antiseptic, even though every second counts because infection is still a concern. And then you insert the needle, pushing it through skin and muscle and the tough pleural membrane, and suddenly there's a rush of air, a hissing sound as the trap pressure releases, and Michael takes a deep gasping breath, and you can see the color starting to return to his face. The oxygen saturation on the monitor starts climbing, 89, 91, 93, 95. You just saved this man's life, performed an emergency procedure that required you to make a split-second diagnosis and act on it with confidence despite the inherent risks. And it worked. He's stable. He's breathing. His blood pressure is holding steady. And you've been in the hospital for exactly 28 minutes. There's no time to feel relief or satisfaction or anything resembling a normal human emotional response to having just prevented someone from dying. Because the ER doesn't stop for your feelings, doesn't pause to let you process the adrenaline dump that's currently making your hands shake slightly, doesn't care that you just performed a life-saving procedure and might want a moment to collect yourself. The overhead speaker crackles to life with a tone that every emergency department provider learns to dread. Ambulance en route, ETA, 3 minutes, 37-year-old female, unresponsive, possible overdose, CPR in progress, which means you've got a cardiac arrest incoming, someone whose heart has stopped beating, whose brain is currently being deprived of oxygen with every passing second, and you need to mobilize your team and prepare the resuscitation bay immediately. You hand off Michael to another provider with quick instructions to get the chest tube supplies ready, because that needle decompression is just a temporary fix. He's going to need a proper chest tube placed to keep the lung expanded. And then you're calling out orders as you head toward the resus bay. I need respiratory therapy. I need pharmacy up here with the code cart. Someone get the ultrasound machine. and I want 2 large bore IVs ready to go the second she comes through the door. The resuscitation bay is this bizarre combination of high-tech medical equipment and barely controlled chaos. There are monitors covering every wall, showing heart rhythms and oxygen levels and blood pressure readings. There's a ventilator standing ready to breathe for the patient. There are drawers full of medications and equipment and emergency supplies. And in the center of it all is a bed where someone is about to either be brought back from the edge of death or officially declared beyond saving. Your team assembles in under 2 minutes, which is actually impressive considering how busy the department is. 2 nurses, a respiratory therapist, a pharmacist, and a tech who's there to document everything, because even in the middle of a code, someone has to write down every single action and medication and timestamp for the medical record. The paramedics burst through the doors, and they're doing chest compressions on a young woman who looks even younger than her stated age of 37, and you get the full story as they transfer her to your bed. Her name is Jennifer. Her roommate found her unconscious on the bathroom floor about 20 minutes ago. There were empty pill bottles scattered around her. The roommate thinks it was her prescription, oxycodone plus maybe some benzodiazepines. She called 911 immediately. The paramedics arrived and found her not breathing with no pulse. They've been doing CPR for approximately 15 minutes. They gave her 2 doses of naloxone, which is the overdose reversal medication, but there was no response. They intubated her in the field, and they've been ventilating her manually, and her cardiac rhythm is currently showing PEA, which stands for pulseless electrical activity, meaning the heart is generating electrical signals but not actually pumping blood. You take over the resuscitation, calling out orders in a rapid-fire sequence that your team executes with practiced efficiency. Continue compressions. I want them hard and fast. Minimize interruptions. Give me 1 milligram of epinephrine IV push. Respiratory. Confirm that tube placement. I want an end-tidal CO2 reading. Someone get me a glucose check, and let's get a full toxicology screen. And I need an ultrasound. I want to see what the heart is doing. The room erupts into coordinated action, everyone moving with purpose, and you're doing the mental calculations that every ER doctor has to do during a code. She's been down for at least 15 minutes, maybe longer, depending on how long she was on that bathroom floor before her roommate found her. And every minute without oxygen causes irreversible brain damage. So even if you get her heart beating again, there's a very real possibility that she's going to have permanent neurological deficits or be in a persistent vegetative state. The compressions continue. Someone's hands locked over Jennifer's sternum, pushing down hard enough to compress the chest 2 inches with every thrust. And you can hear the sickening crack of ribs breaking under the pressure, which is normal and expected because effective CPR requires enough force to actually pump blood through the body, and that force inevitably fractures ribs, leaving the patient with broken bones they'll need to heal from if they survive this at all. The respiratory therapist confirms that the breathing tube is properly placed in her trachea and not accidentally shoved down into her esophagus, which happens more often than anyone likes to admit, and you can see the waveform on the monitor showing end-tidal carbon dioxide, which means air is moving in and out of her lungs and she's exchanging at least some gas, which is good, but her pupils, when you check them with your pen light, are blown wide open and non-reactive, which is distinctly not good because it suggests significant brain injury already. The ultrasound probe is on her chest, and you're looking at the grainy black and white image on the screen, watching her heart. And what you see is both encouraging and terrifying. The heart is moving. There's actual cardiac activity happening, but it's weak and uncoordinated and clearly not generating enough pressure to create a pulse, which confirms the PEA rhythm you're seeing on the monitor. You give another round of epinephrine, that powerful stimulant that's supposed to make the heart squeeze harder, contract more forcefully, and you're running through the possible reversible causes in your head because that's what you're trained to do. There's a mnemonic they teach you in medical school called the H's and T's: hypovolemia, hypoxia, hydrogen ion, which means acidosis, hyper or hypokalemia, meaning potassium imbalances, hypothermia, then tension, pneumothorax, tamponade, toxins, and thrombosis, either pulmonary or coronary. Most of those don't apply here, but toxins, that's the obvious culprit. She's got a belly full of opioids and benzodiazepines, shutting down her respiratory drive and probably her cardiac function too. And you've already given naloxone, which should reverse the opioids, but there's no specific reversal agent for benzos that's going to work fast enough to help in this situation. The blood glucose comes back normal, so at least she's not hypoglycemic. And you order a whole panel of lab work: complete blood count, comprehensive metabolic panel, liver function, arterial blood gas to see how acidotic she is, troponin to check for cardiac damage, and that toxicology screen to confirm exactly what she took. But here's the brutal reality of overdose codes. Sometimes people take too much of something and their body just shuts down, and no amount of advanced medical intervention can restart it, especially if they've been down too long before anyone found them. You're at the 18-minute mark now since the paramedics first arrived, which means Jennifer has been without a meaningful pulse for over 30 minutes total, and the research is pretty clear about what happens to the human brain after that long without adequate oxygen. Even if you do get her back, she might never really be back, not in any meaningful sense. The nurses are looking at you, waiting for direction, and you can see in their eyes that they're thinking the same thing you're thinking. Maybe it's time to call it, to stop the code and pronounce her dead, because at this point you're just going through the motions and possibly creating a situation where you bring back a body but not a person. But there's a roommate in the waiting room right now, someone who found her friend and called for help and is desperately hoping that the doctors can work a miracle, and you're not quite ready to walk out there and deliver the news that would shatter that hope. So you make a decision that's part medicine and part stubborn refusal to give up. Let's try one more round. Give another milligram of epi, continue compressions, and get me 4 amps of sodium bicarb to correct the acidosis. And someone call the ICU. If we get her back, she's going straight upstairs. The sodium bicarbonate goes in. That alkaline solution meant to counteract the buildup of acid in her blood from prolonged oxygen deprivation. And you're watching the monitor with an intensity that's almost painful, looking for any change in the rhythm, any sign that her heart might be responding to all these medications and interventions you're throwing at it. The compressions continue, relentless, mechanical, and you find yourself counting along silently in your head, 100 beats per minute. The rhythm of the Bee Gees' Stayin' Alive, which is both darkly ironic and actually the recommended tempo for proper CPR. 32 minutes without a pulse now, 33 minutes. The chance of meaningful neurological recovery is approaching 0, and you're about to make the call to stop when suddenly the rhythm on the monitor changes. Instead of the disorganized electrical activity you've been seeing, there's a recognizable pattern emerging, a QRS complex that actually looks like a real heartbeat, and then another one and another one. Someone calls out, "I've got a pulse," and you reach for her neck, fingers pressing into the carotid artery, and there it is, weak, but definitely present, a pulse, the feeling of blood actually moving through her arteries because her heart is beating on its own again. The room erupts in controlled excitement, everyone moving with renewed purpose because you got her back, she's alive again in the most technical sense. But now comes the really hard part, keeping her alive and trying to minimize the brain damage that almost certainly occurred during those 33 minutes of inadequate circulation. You order a whole new cascade of interventions, start a dopamine drip to support her blood pressure because even though her heart is beating, it's not beating strong enough to maintain adequate perfusion on its own. Get a cooling protocol started because therapeutic hypothermia, lowering the body temperature to slow down the metabolic processes that cause further brain injury, is one of the few interventions that's actually been shown to improve outcomes after cardiac arrest. Get a stat CT scan of her brain to see if there's any obvious bleeding or swelling. Call the toxicology service for recommendations on managing the ongoing effects of whatever cocktail of drugs is still in her system. And most importantly, get her upstairs to the ICU where she can be monitored continuously by people who specialize in keeping barely stable patients from crashing again. But even as you're giving these orders, even as your team is executing them flawlessly, you're painfully aware that bringing someone back from a cardiac arrest is only the first step. And honestly, often the easy part. The real question is, what kind of life did you just restore? Is Jennifer going to wake up in a few days confused but essentially herself, able to recognize her loved ones and eventually return to some semblance of normal life? Or is she going to remain in a coma, sustained by machines, her brain too damaged to ever regain consciousness, putting her family in the impossible position of deciding when to withdraw life support? Or maybe she'll wake up but be profoundly impaired, unable to speak or move or take care of herself, trapped in a body that no longer follows her commands. These are the questions that haunt every ER doctor, the uncertainty that comes with every resuscitation, and they never get easier no matter how many times you go through this process. The ICU resident arrives to take her upstairs, and you give him the full rundown, every detail of the code, every medication given, every intervention performed, and then she's gone, wheeled out of your resus bay and out of your immediate responsibility, though you know you'll be checking on her status obsessively for the next several days. You look at the clock on the wall, one of those institutional round clocks that seem to exist exclusively in hospitals, and realize that the entire code took 45 minutes from the moment the paramedics arrived to the moment Jennifer left your department. 45 minutes that felt simultaneously like hours and like seconds. And you've been at work for exactly 1 hour and 13 minutes. You step out of the resuscitation bay and immediately you're confronted with the fact that the rest of the emergency department did not pause while you were running that code, did not wait patiently for you to finish saving someone's life before piling on more demands and more patients and more crises. The waiting room has grown from 30 people to 47, according to the triage nurse who catches you at the door with a look that's equal parts sympathy and urgency, And she's got 3 patients she needs you to see immediately because they've been waiting so long that they're threatening to leave against medical advice and file complaints with the hospital administration. There's an 82-year-old woman with altered mental status who might be having a stroke, which means you've got a narrow window to give clot-busting medication if that's what this is. But you need to get a CT scan of her brain first to make sure it's not a bleed, because giving thrombolytics to someone with a hemorrhagic stroke will kill them. There's a 6-year-old boy with a high fever and a rash that could be anything from a simple viral infection to meningitis. And the mother is understandably terrified and demanding answers that you don't have yet because you haven't even examined the kid. And there's a 45-year-old man with crushing chest pain radiating to his left arm, which is textbook for a heart attack. And he's already had 2 abnormal EKGs suggesting cardiac ischemia, but cardiology hasn't responded to your consult request from 45 minutes ago because apparently they're dealing with their own emergencies upstairs. Michael, your construction worker with the pneumothorax, is back in your consciousness now because the nurse is telling you that surgery still hasn't come down to place the chest tube, even though you called them over an hour ago, and his oxygen levels are starting to drift down again. And the needle decompression you did is only a temporary measure that's probably not holding anymore. The patient in bed 8, the one with chest pain who wanted to be seen immediately, is now demanding to speak to a supervisor and threatening to leave because she's been here for 90 minutes and hasn't been examined by a doctor yet. Never mind the fact that her EKG was completely normal and her troponin was negative and she's probably having an anxiety attack rather than a cardiac event. But you still need to see her and document everything and make sure you're not missing something, because missing a heart attack is one of the most common reasons ER doctors get sued. The patient in bed 12, the one whose discharge papers you were supposed to sign an hour ago, is still here because you never got around to signing those papers. And now he's angry and the nurse is frustrated, and it's just one more thing that's fallen through the cracks in the chaos of your morning. And all of this, every single thing I just described, is happening simultaneously right now, all demanding your immediate attention. And you've got to somehow prioritize, got to figure out which crisis is most urgent, which patient is most likely to deteriorate if you don't see them right this second. The brutal calculus of emergency medicine. You've got limited time and limited resources and unlimited demand. So you have to make choices about who gets your attention first, knowing that whatever choice you make means someone else is going to wait longer and potentially suffer for it. You decide the stroke patient takes priority because there's a time-sensitive treatment window. So you rush to her bedside, and she's this tiny elderly woman who looks confused and frightened. And when you ask her to smile, her face droops on the right side. When you ask her to lift her arms, the right one drifts downward. And when you ask her to repeat a simple phrase, her speech is slurred and garbled. This is a stroke, no question. The classic signs of left-sided brain. Damage affecting the right side of her body. And you need to move fast. You order the stat CT scan of her brain, emphasizing to everyone within earshot that this is a potential stroke and time is brain tissue. Every minute that passes means more neurons dying, more permanent disability accumulating, and the CT tech needs to take her immediately, not in 20 minutes, not when they finish with their current patient, but right now. While you're waiting for the CT to happen, you're at the bedside of the 6-year-old with the fever and rash. And children are a whole different level of stress in emergency medicine because kids can look relatively okay and then crash suddenly and catastrophically. their bodies compensating and compensating and compensating until they just can't anymore and everything falls apart at once. The boy's name is Lucas, and he's lying on the bed looking miserable, his mother sitting beside him with that particular expression of parental fear that you've seen 1,000 times, but still hits you in the chest every single time. You examine him carefully, methodically. His temperature is 103.8, which is high but not dangerously so. His heart rate is elevated, which is expected with fever. The rash is scattered across his trunk and arms, small red spots that don't blanch when you press on them, which is concerning because non-blanching rashes can indicate bleeding under the skin, which can be a sign of serious bacterial infection like meningococcal disease, which can kill a child in hours. But non-blanching rashes can also be completely benign, caused by viral infections or even just the mechanical trauma of coughing or vomiting. You press a glass against the rash, the classic test to see if the spots disappear under pressure, and they don't, which increases your concern but doesn't definitively tell you anything. His neck is supple, no stiffness that would suggest meningitis. He's alert and interactive, albeit cranky, which is reassuring because kids with serious infections tend to be lethargic and unresponsive. But you can't rule out meningitis based on a physical exam alone, especially in a kid this young. So you're faced with a decision that no parent wants to hear and no doctor enjoys making. He needs a lumbar puncture, a spinal tap, where you insert a needle into his lower back and withdraw some cerebrospinal fluid to test for bacteria and white blood cells that would indicate infection of the brain and spinal cord. You explain this to the mother, trying to be both honest about the necessity and reassuring about the safety, and you can see the fear in her eyes escalating because nobody wants to hear that their child needs a needle stuck into their spine. But you emphasize that if this is meningitis and you don't treat it aggressively and immediately, her son could die or suffer permanent brain damage. And that's not hyperbole. That's just the cold medical reality. She agrees. What choice does she have? And you call for the lumbar puncture tray and prepare to do this procedure, which is technically challenging in the best circumstances and even more difficult in a scared, crying, feverish child who's going to fight you every step of the way. But before you can even get the tray open, your pager goes off, which is immediately followed by the overhead speaker, code blue, CT scanner, code blue, CT scanner. And your stomach drops because you know exactly who that is. It's your stroke patient, the 82-year-old woman. Something has gone wrong during her scan. And you're running, sprinting down the hallway toward the CT suite. And when you burst through the doors, you find the CT tech doing chest compressions on your patient, who is now in full cardiac arrest. Her heart has stopped, probably from the stress of the stroke combined with whatever underlying cardiac disease she undoubtedly has at her age. And now you're running another code, your second one of the shift, and you haven't even been at work for 2 hours yet. The code in the CT scanner is complicated by the fact that you're in a confined space surrounded by expensive imaging equipment that can't be exposed to the magnetic fields of a defibrillator. So you have to move her, get her out of the scanner and back to the resuscitation bay. And every second you spend moving her is a second she's not getting adequate CPR, not getting the chest compressions that are keeping some minimal amount of blood flowing to her brain. You're coordinating the move while simultaneously running the code, calling out orders while helping to lift her fragile body onto a transport stretcher, And you can feel the fear and adrenaline coursing through your system again, because this is exactly the kind of situation where mistakes happen, where something gets overlooked or someone miscommunicates and a patient dies as a result. Back in the Resus Bay, which was just cleaned and restocked after Jennifer's code, you've got compressions going, you're attaching monitor leads, getting IV access, and you're looking at the rhythm on the monitor, which shows ventricular fibrillation, which is actually good news in the twisted logic of cardiac arrest, because VFib is a shockable rhythm, meaning you can use the defibrillator to try to reset her heart back into a normal pattern. You charge the defibrillator to 200 joules, everyone clears away from the patient, and you deliver the shock, her body jerking with the electrical current, and you immediately resume compressions while checking the monitor to see if the shock worked. It didn't. She's still in VFib, so you give epinephrine, you continue compressions, and after 2 minutes you shock her again, 360 joules this time, maximum energy, and again her body convulses, and again you check the monitor, and this time the rhythm has changed to an organized complex that might be generating a pulse. You check for a carotid pulse, and there it is, faint but present, and she's back twice in one morning. You've brought someone back from cardiac arrest, but again you're immediately faced with the same questions about what kind of recovery is possible, especially in an 82-year-old who was already having a massive stroke before her heart stopped. The ICU is called again. She's stabilized as much as possible and sent upstairs, and you never did get that CT scan of her brain to confirm the stroke diagnosis, so now she's going to need that done in the ICU, assuming she survives long enough for it to matter. You're physically and emotionally drained. Your scrubs are soaked with sweat. Your hands are shaking from the adrenaline, and you desperately need 30 seconds to just breathe and process what just happened. But the ER is still full, still demanding your attention, and that 6-year-old who needs a lumbar puncture is still waiting, and the chest pain patient who might be having a heart attack is still waiting, and Michael with the pneumothorax still needs his chest tube, and the 47 people in the waiting room are still waiting, and you've been at work for 1 hour and 56 minutes, and you have 10 hours and 4 minutes left in your shift. And this is what it means to be an emergency room doctor. This relentless, grinding, never-ending cascade of human suffering and medical crises that just keeps coming and coming and coming until your shift ends and you hand it all off to the next person who will go through exactly the same thing. And we're just getting started. You force yourself back to Lucas, the 6-year-old with the fever and rash, and his mother looks at you with that mixture of hope and terror that parents get when they've been waiting for the doctor to come back, wondering if the delay means something terrible has happened or if you've just been busy with other patients. You don't explain about the code. Don't tell her that someone just died and came back to life in the CT scanner, because that information serves no purpose except to further frighten her. So instead you focus on her son, on getting the supplies ready for the lumbar puncture that you should have done 20 minutes ago, but couldn't because someone else's emergency took precedence. The pediatric lumbar puncture kit is designed to be as minimally traumatic as possible, with a smaller needle and a numbing spray that's supposed to make the procedure less painful. But the reality is that you're still going to stick a needle into a child's spine while his mother watches, and there's no way to make that not terrifying for everyone involved. You position Lucas on his side, curled up in the fetal position, knees to chest, chin tucked down, which opens up the spaces between the vertebrae in his lower back and gives you access to the subarachnoid space, where the cerebrospinal fluid flows around the spinal cord. The nurse is helping hold him still, which sounds simple but is actually crucial, because if he moves at the wrong moment while you've got a needle in his spine, you could cause serious damage. You clean the area with antiseptic, the cold liquid making Lucas flinch and whimper, and his mother is holding his hand and telling him it's going to be okay, telling him to be brave, and you can hear the tears in her voice even though she's trying to stay strong for her son. You inject local anesthetic into the skin and deeper tissues, which requires a small needle stick that Lucas definitely feels, and he cries out and tries to twist away, but the nurse holds him steady, and you talk to him in that calm, reassuring voice that you've perfected over years of doing procedures on scared patients. I know it hurts, buddy. I'm sorry. But we're almost done. You're doing so great. Just a little bit longer. The anesthetic takes effect, numbing the area, and now comes the actual lumbar puncture. You take the spinal needle, longer and thinner than the one you used for the anesthetic, and you insert it right in the midline between the fourth and fifth lumbar vertebrae, advancing it slowly, carefully, feeling for the subtle change in resistance that tells you when you've penetrated through the ligaments and into the subarachnoid space. There's an art to this procedure, a tactile sense that you develop with practice, because if you go too shallow, you won't get any fluid. But if you go too deep, you could theoretically hit the spinal cord itself, which sits higher up but still represents a psychological fear that makes this procedure stressful, even for experienced physicians. You feel the pop as the needle goes through the final layer, and you remove the stylet from inside the needle, and clear cerebrospinal fluid starts dripping out, drop by precious drop, into the collection tubes you've positioned beneath the needle hub. You need 3 tubes, each with about a milliliter of fluid, which doesn't sound like much, but when it's dripping out 1 drop at a time from a scared child's spine, it feels like it takes forever. The fluid is crystal clear, which is a good sign, because if Lucas had bacterial meningitis, you'd expect the fluid to be cloudy or even frankly purulent, but you still need to send it to the lab for cell counts and culture and chemistry analysis to definitively rule out infection. You collect the samples, withdraw the needle, place a bandage over the site, and tell Lucas he did an amazing job, which he did, and his mother is crying with relief that it's over, and you send the tubes to the lab with instructions to run them stat, meaning immediately, because if this kid has meningitis, he needs antibiotics. Started in the next hour, not in 6 hours when the lab gets around to processing routine samples. While you're waiting for Lucas's labs to come back, which the lab promises will take at least 45 minutes and will probably take closer to 90 because they're backed up with samples from the entire hospital, you finally make it over to the chest pain patient who's been waiting to see you for almost 2 hours now. His name is David. He's 45 years old, with a history of high blood pressure and high cholesterol and a 30-year smoking habit, which means he has about half a dozen risk factors for coronary artery disease, and he's describing classic cardiac symptoms: crushing substernal chest pain that started about 3 hours ago, radiating to his left arm and jaw, associated with shortness of breath and nausea and diaphoresis, which is the medical term for sweating profusely. And his EKGs, and he's had 3 of them now, show ST segment elevations in the anterior leads, which is the electrical signature of a heart attack, specifically an ST elevation myocardial infarction, or STEMI, meaning one of his coronary arteries is completely blocked and the muscle tissue that artery supplies is actively dying right now, being starved of oxygen and turning necrotic. This is a true emergency. a time-sensitive condition where every minute of delay means more heart muscle lost. And the treatment is either emergency angioplasty, where a cardiologist threads a catheter up through the arteries and opens the blockage, or thrombolytic drugs that dissolve the clot, and you need to make this happen immediately. You've been calling the on-call cardiologist for over an hour, leaving messages, sending pages, having the unit coordinator call the answering service, and you've gotten exactly zero response, which is both infuriating and unfortunately not that uncommon, because consultants are often managing multiple emergencies across different hospitals, and sometimes they simply can't respond as quickly as you need them to. So you make a command decision. You're going to give thrombolytics, specifically tenecteplase, a powerful clot-busting drug that will hopefully dissolve the blockage in David's coronary artery and restore blood flow before too much damage occurs. But thrombolytics are dangerous. They work by essentially removing the body's ability to clot blood, which means if David has any source of active bleeding or any condition that could cause bleeding, you could kill him just as surely as the heart attack will. You run through the contraindications in your head, the list of reasons not to give this drug: recent surgery or trauma, history of bleeding disorders, uncontrolled high blood pressure, recent stroke, and about a dozen other conditions. And David doesn't have any of them. So you explain the risks and benefits to him, get his verbal consent, because there's no time for written paperwork when someone is actively infarcting, and you order the tenecteplase. The pharmacist brings it up from the pharmacy, this small vial containing a powder that gets reconstituted with sterile water, and it's given as a single intravenous bolus based on the patient's weight, and you administer it yourself, pushing it slowly through his IV line. And now all you can do is wait and watch the monitor and pray that it works, that the clot dissolves, that blood flow is restored, that you made the right call. Within 15 minutes, David's chest pain starts to improve, going from a 10 out of 10 to a 6 out of 10, and the ST segments on his EKG are starting to come down, normalizing, which suggests that reperfusion is happening, blood is flowing again, and you might have just saved this man's life, or at least saved a significant portion of his heart muscle from permanent damage. The cardiologist finally calls back 45 minutes after you gave the thrombolytic, and you explain what you did and why you did it, and there's a pause on the other end of the line, and you're preparing for criticism or anger, but instead the cardiologist just sighs and says, "Good call, I would have done the same thing. I'll come in and take him to the cath lab to make sure the artery stays open." 3 hours into your shift now, and you're finally getting a chance to eat something, which in the emergency department means wolfing down whatever you can find in approximately 90 seconds while standing at the nurse's station before the next crisis demands your attention. You've got a granola bar that you found in your bag, and it tastes like cardboard and sadness, but it's calories. And you haven't eaten anything since dinner last night, and you can feel your blood sugar dropping and your thinking getting fuzzy, which is dangerous when you're making life and death decisions. The patient board on the wall, this massive digital display that shows every patient in the department along with their chief complaint and how long they've been waiting, is a sea of red and yellow, indicating people who have been here too long, who are overdue to be seen, who are at risk of decompensating while they wait. You've got 28 patients currently in beds and another 51 in the waiting room, and the hospital is on diversion for ambulances because there are literally no empty beds in the entire building. But ambulances keep coming anyway because when someone calls 911, the paramedics have to take them somewhere. And if every hospital in the city is full, then diversion status doesn't actually mean anything. Your pager goes off again, because of course it does, and it's the lab calling with critical results on one of your patients. The guy in bed 14 who came in with vague abdominal pain and looked relatively stable has a white blood cell count of 32,000, which is more than 3 times the normal level, and his lactate is elevated at 4.7, which suggests that somewhere in his body tissue is not getting enough oxygen and is switching to anaerobic metabolism. And when you put those findings together with abdominal pain, you start thinking about things like ruptured appendix or perforated bowel or mesenteric ischemia, where the blood supply to the intestines gets cut off and the bowel starts dying. You pull up his CT scan, which finally got done about 40 minutes ago, and you're scrolling through the images, these cross-sectional slices of his abdomen, looking at liver and spleen and kidneys and stomach and intestines. And there, right there in the right lower quadrant, you can see a dilated loop of small bowel with thickened walls and surrounding fat stranding. And the radiologist's report that just popped up on the screen confirms what you're seeing. Findings consistent with acute appendicitis with possible perforation. This man needs surgery, needs it soon, because if that appendix has actually burst, then he's got bacteria and fecal material spilling into his abdominal cavity, causing peritonitis. And if you don't get him to the operating room, he's going to develop sepsis and potentially die. You call the surgery service, and after being on hold for what feels like an eternity but is probably only 3 minutes, you get through to the chief resident, who listens to your presentation and says they'll come down to evaluate the patient. But they're currently in the middle of a case in the OR, and it might be an hour before they can get to the ER. An hour. You've got a patient with a potentially ruptured appendix, and the surgeons can't see him for an hour, which is not their fault because they're probably dealing with their own emergency. But it puts you in this impossible position where you know what the patient needs, but you can't actually provide it because you're dependent on other specialties to follow through. So you do what you can. You order broad-spectrum antibiotics to start treating the infection. You give IV fluids to support his blood pressure. You order pain medication, even though there's this outdated surgical teaching that you shouldn't give pain meds before the surgeons examine the patient because it might mask their findings, which is complete nonsense. That's been disproven by multiple studies, but some surgeons still cling to it like a religious belief. You explain to the patient that he likely has appendicitis and will need surgery, and he asks when, and you have to tell him you don't know, probably sometime in the next few hours, which is both honest and completely inadequate because he's scared and in pain and wants definitive answers that you simply cannot provide. The nurse assigned to the trauma bay is calling you over with an urgency that makes your stomach clench. And when you get there, you find paramedics wheeling in a teenager, maybe 16 or 17 years old, and he's covered in blood. And the story you get is that he was stabbed multiple times in a fight outside a convenience store, and the knife wounds are in his chest and abdomen, and he's conscious but deteriorating fast. His blood pressure is low at 80/50. His heart rate is 140, and he's breathing rapidly. His skin is pale and cool and clammy, all signs of hemorrhagic shock, meaning he's losing blood faster than his body can compensate. You don't have time for a full history or a detailed examination. You need to move fast. So you're doing a primary survey while simultaneously calling out orders. Get me 2 units of O negative blood from the blood bank immediately, not in 10 minutes, right now. Someone call surgery and tell them we have a penetrating trauma to chest and abdomen, possible hemothorax and hemoperitoneum, and he needs the OR as soon as possible. Get a chest x-ray portable, and I want a fast exam. The fast exam is a focused ultrasound assessment that lets you quickly look for free fluid, meaning blood, in the chest and abdominal cavities. And you're doing it yourself because you need the information immediately, running the ultrasound probe over his chest and abdomen while the nurses are cutting off his clothes and establishing large bore IV access. The ultrasound shows dark fluid in the pericardial space around his heart, which means blood is accumulating in the sac that surrounds the heart, and it's starting to compress the heart, preventing it from filling properly, a condition called cardiac tamponade that will kill him in minutes if you don't relieve it. You also see free fluid in the abdomen, more blood, and his blood pressure is dropping further, now 70/40, and his level of consciousness is declining, his eyes rolling back, and you realize that he's about to code. His heart is about to stop because it's being compressed by blood, and because he's lost so much blood volume that there's simply not enough to fill his circulatory system. You make another split-second decision, one that would have seemed insane to you back in medical school, but is now just part of the job. This kid needs an emergency pericardiocentesis, meaning you're going to stick a needle into the sac around his heart and drain the blood that's compressing it. And you need to do it right now without waiting for ultrasound guidance or consultant backup or any of the safety measures you'd normally want. You grab the pericardiocentesis kit, prep the skin below his sternum with antiseptic, and insert a long needle at a 45-degree angle aiming toward his left shoulder, advancing it carefully while watching the ultrasound screen. And you see the needle tip enter the pericardial space and suddenly dark. Red blood is flowing back through the needle into the syringe, and you're aspirating it, pulling it out, draining the tamponade, and on the monitor you can see his blood pressure starting to rise, 75/45, 80/50, and he takes a deeper breath and his eyes flutter open slightly. You've bought him time, temporarily decompressed the tamponade, but he's still bleeding actively into his chest and abdomen, and he needs surgery immediately. Needs a trauma surgeon to open him up and find the bleeding vessels and stop them before he exsanguinates completely. The trauma surgery team arrives, finally, and they take one look at the patient and agree he needs to go straight to the OR, no time for any additional imaging or workup, and they're wheeling him out while hanging blood products and maintaining pressure on his wounds, and you're left standing in the trauma bay with blood covering your scrubs and your hands and splattered across your face shield, and you realize that you don't even know his name, this teenager whose life you just saved, at least temporarily. And you'll probably never know if he survived the surgery or what happened to him afterward, because that's just how emergency medicine works. You stabilize them and send them on and rarely get closure or follow-up. You need to clean up, need to change out of these blood-soaked scrubs. But there's no time because the department is still overflowing and the waiting room is still full, and your pager is going off yet again with another critical lab result, this time for a different patient, a 68-year-old woman with a potassium level of 7.2, which is dangerously high, high enough to cause fatal cardiac arrhythmias, and you need to treat this immediately. Hyperkalemia, the medical term for elevated potassium, can kill in two ways. It can cause the heart to develop ventricular fibrillation and arrest, or it can cause the heart to just stop beating altogether in what's called asystole. And both outcomes are obviously bad. So you've got a very narrow window to get her potassium down before something catastrophic happens. You go to her bedside, and she's on dialysis 3 times a week for end-stage kidney disease. And she missed her dialysis appointment yesterday because she didn't have transportation. And now her potassium is built up to lethal levels because her kidneys can't eliminate it. You order the standard hyperkalemia treatment protocol, calcium gluconate first, which doesn't lower the potassium but stabilizes the cardiac membrane and makes the heart less likely to develop arrhythmias while you're working on actually reducing the potassium level. Then insulin and dextrose, because insulin drives potassium from the bloodstream into the cells, and you give dextrose along with it to prevent hypoglycemia. Then albuterol nebulizer, because beta agonists also help shift potassium intracellularly. And finally, sodium polystyrene sulfonate, which binds potassium in the gut so it can be eliminated in the stool, though this works slowly over hours rather than minutes. But the real treatment she needs is dialysis. Needs to have her blood filtered through a machine that can remove the excess potassium, and you're calling the nephrology service trying to arrange emergency dialysis, and they're telling you that the dialysis unit is full and the earliest they can take her is in 4 hours, which might as well be next week given how critical her potassium level is. So you're stuck managing her medically, repeating the potassium level every 2 hours to make sure it's coming down, keeping her on a cardiac monitor in case she develops arrhythmias, and basically hoping that she doesn't code before nephrology can dialyze her, which is a terrible position to be in, but sometimes that's all you can do in emergency medicine. Manage the crisis as best you can with inadequate resources and hope that nothing goes catastrophically wrong. 4 hours into your shift, and you haven't sat down once except for the 90 seconds you spent eating that granola bar. Your feet are aching, your back is sore from leaning over patients, your throat is dry because you haven't had time to drink water, and you desperately need to use the bathroom, but there's literally no gap in the patient flow that would allow you to step away for even 2 minutes. This is the physical reality of emergency medicine that nobody talks about. The job is not just mentally and emotionally exhausting, it's physically brutal, requiring you to be on your feet for 12-hour shifts, often longer if the next shift is late or if there's a critical patient you need to finish caring for before you can leave. Your bladder is sending urgent signals that it needs attention, but you're evaluating a new patient, a 74-year-old man with sudden onset of severe back pain, and the way he's describing the pain, this tearing sensation that started in his chest and migrated to his back, combined with his history of high blood pressure, is making you think about aortic dissection, which is one of the most lethal cardiovascular emergencies, where the inner layer of the aorta tears in blood starts tracking between the layers of the arterial wall. And if it ruptures completely, the patient will bleed out internally in seconds. You order a CT angiogram of his chest and abdomen, the definitive test for aortic dissection, and you're giving him blood pressure medications because high blood pressure makes the dissection worse, can cause it to extend or rupture, and you need to keep his systolic pressure below 120, which requires aggressive treatment with IV medications that you have to titrate carefully to avoid dropping his pressure too low and causing other problems. While you're managing this potential aortic dissection, you get a call from the triage nurse that there's a psychiatric emergency in the waiting room, a 28-year-old woman who came in saying she's suicidal and has a plan to overdose on pills when she gets home. And by law, you can't let her leave. You have to evaluate her and determine if she needs to be admitted to the psychiatric unit or if she can be safely discharged with outpatient follow-up. But the psychiatric unit is full, has been full for weeks, and even if you determine she needs admission, she'll probably end up boarding in the ER for days waiting for a bed to open up, during which time she'll need constant one-on-one monitoring by a sitter to make sure she doesn't hurt herself, which takes up a bed and a staff member that you desperately need for medical patients. This is the crisis in psychiatric care that emergency departments are left to manage. There aren't enough inpatient psychiatric beds, there aren't enough outpatient resources, and so people in mental health crisis come to the ER because it's the only place that has to take them by law. And emergency physicians who have minimal psychiatric training are forced to make complicated risk assessments about who's truly at risk of suicide and who can be safely discharged. You go to see the psychiatric patient, and she's sitting in the waiting room crying, and when you bring her back to a room and start talking to her, the story that emerges is heartbreaking. She lost her job 3 months ago. She's behind on rent and about to be evicted. Her boyfriend left her. She feels hopeless and worthless, and she's been having persistent thoughts of suicide for the past week. And last night she actually took out the bottle of pills and sat with it for an hour before deciding to come to the ER instead. This is clearly someone in acute crisis who needs help, but the help she needs isn't really emergency medical care. It's stable housing and employment assistance and intensive psychotherapy and medication management, none of which you can provide in the emergency department. You can admit her to the psychiatric unit, keep her safe for a few days, maybe adjust her antidepressant medication, but unless the underlying social and economic factors that precipitated this crisis are addressed, she's going to be right back here in a few weeks or months. But those underlying factors are completely outside your control, outside the healthcare system's control, really. And so you do what you can. You complete a thorough suicide risk assessment. You determine that she does need inpatient psychiatric care because her suicidal ideation is active and she has a specific plan. And you call the psychiatric consult service to arrange admission, knowing that she's probably going to spend the next 72 hours in an ER bed waiting for transfer, because that's just how the system works, or more accurately, fails to work. The CT results come back on your potential aortic dissection patient, and your stomach sinks when you read the radiologist report. There is indeed a type B aortic dissection, meaning it involves the descending aorta, and it extends from just beyond the left subclavian artery all the way down into the abdominal aorta, a massive dissection that could rupture at any moment. You need a vascular surgeon or a cardiothoracic surgeon immediately, and you're making the calls, coordinating the care, and the patient is asking you what's wrong, and you have to tell him that there's a tear in his major artery and he needs emergency surgery. And you can see the terror in his eyes as he processes this information, realizes that he's in immediate mortal danger. And there's nothing you can say that's going to make this less frightening, because it is genuinely terrifying. 5 hours into your shift, you finally get a 30-second break to use the bathroom, and as you're washing your hands afterward, you catch a glimpse of yourself in the mirror and you barely recognize the person staring back at you. There are dark circles under your eyes, your hair is disheveled. There's a splatter of blood on your neck that you missed when you changed scrubs. And you look absolutely exhausted, which makes sense because you are absolutely exhausted. Running on nothing but adrenaline and that inadequate granola bar from 3 hours ago. You head back to the main ER area and immediately you're confronted with a new crisis. Lucas the 6-year-old with the fever and rash whose spinal tap you did hours ago. His lab results are finally back, and the cerebrospinal fluid analysis shows elevated white blood cells and low glucose, which is the signature pattern of bacterial meningitis, meaning your worst fears were correct. This child has a life-threatening infection of the membranes covering his brain and spinal cord. You need to start antibiotics immediately, broad-spectrum coverage with ceftriaxone and vancomycin, because bacterial meningitis can cause brain damage or death within hours, if not treated aggressively. And you're explaining this to his mother, trying to be both honest about the severity and reassuring about the treatment, and she's crying and asking if her son is going to die. And you have to tell her that you don't know that bacterial meningitis is serious and can be fatal, but the fact that you caught it early and are starting treatment now gives him the best possible chance. Lucas needs to be admitted to the pediatric intensive care unit, needs close monitoring and IV antibiotics and possibly other interventions if he develops complications like seizures or increased intracranial pressure. And you're calling the PICU team to arrange transfer, and while you're on the phone with them, you're also keeping one eye on the patient board, because there are multiple other patients who need your attention. The patient with appendicitis that you called surgery about hours ago, he's still waiting, and his white blood cell count has continued to rise, and his pain is getting worse, despite the medications you've given him. And when you examine him again, his abdomen is rigid and he has rebound tenderness, which are signs of peritonitis, meaning that appendix has definitely ruptured and he's got widespread infection in his abdominal cavity now. And you're paging surgery again, more urgently this time. And finally, the surgery resident shows up and examines the patient and agrees that he needs emergency surgery, and they're taking him to the OR. But it's been over 4 hours since you first identified the problem, 4 hours during which his condition deteriorated because the system is so overwhelmed that even emergency surgery can't happen in a timely manner. Michael, your construction worker with the pneumothorax from the beginning of your shift, finally got his chest tube placed, but it took 3 hours and 2 different surgeons before someone actually came down to do it. And during that time, he required 2 additional needle decompressions because the initial one failed, and now he's stable with the tube in place, draining air and blood from his chest cavity. But he's angry, understandably so, about the delays and the repeated procedures and the inadequate pain control, and he's threatening to file a complaint with the hospital administration. And you understand his frustration, but there's nothing you can do except apologize and try to explain that you were doing the best you could with the resources available, which sounds like an excuse, even though it's the truth. David, the heart attack patient who got thrombolytics, went to the cardiac catheterization lab and had a stent placed in his blocked coronary artery. And according to the cardiologist, he did well. The artery is open and blood flow is restored, and he'll probably make a full recovery, which is genuinely good news. One of the few unambiguous successes of your shift so far. 6 hours into your shift, you're supposed to take a lunch break, which is mandated by hospital policy and labor laws, but the department is still completely overwhelmed and there's nobody to cover your patients while you're gone. So you're working through lunch, which is both illegal and extremely common in emergency medicine, because patient care doesn't stop just because you need to eat. You grab another granola bar from your bag and eat it while typing notes into the computer, trying to catch up on documentation, because every patient you see requires a detailed note describing their symptoms. your examination findings, your differential diagnosis, your diagnostic reasoning, the results of tests, your treatment plan, and your final disposition. And these notes take forever to complete properly. And if you don't document something, then legally it didn't happen, which means you could be liable if something goes wrong. The electronic medical record system, which is supposed to make documentation easier and more efficient, is actually a nightmare of drop-down menus and mandatory fields and alerts that pop up constantly, warning you about drug interactions or suggesting preventive care measures that are completely irrelevant to the emergency department setting. And you're clicking through screens and typing and cursing under your breath at the inefficiency of it all. While you're documenting, a new patient arrives by ambulance, a 92-year-old woman from a nursing home who fell and hit her head, and she's on multiple blood thinners for atrial fibrillation and a history of strokes, which means even a minor head injury could cause significant intracranial bleeding, and you need to examine her and get a CT scan of her brain and check her coagulation studies to see how thin her blood is. She's confused at baseline, according to the nursing home staff who sent her, so it's hard to assess if the confusion is new or just her normal state. But she's got a large hematoma on the left side of her forehead where she hit her head, and when you shine a light in her eyes, her right pupil is sluggish to react, which is concerning for increased intracranial pressure from bleeding. The CT scan shows a subdural hematoma, a collection of blood between the brain and the skull, and it's causing midline shift, meaning the blood is taking up enough space that it's actually pushing the brain to one side, and this is a neurosurgical emergency. She needs the operating room to evacuate the hematoma before it causes permanent brain damage or death. You're calling neurosurgery, and the neurosurgeon on call is evaluating another patient at a different hospital and won't be able to get to your hospital for at least an hour. And you're trying to explain that this patient can't wait an hour, that she needs surgery now, but the neurosurgeon is being dismissive, saying that subdurals in elderly patients often don't benefit from surgery, and maybe the best approach is just comfort care. And you're getting frustrated because, this patient could potentially survive if she gets the operation, but she's definitely going to die without it. And you're arguing with the neurosurgeon, trying to advocate for your patient. And finally, the neurosurgeon agrees to at least come evaluate her in person before making a final decision. While you're dealing with this, the overhead speaker announces another ambulance arrival, incoming trauma, ETA 2 minutes, motorcyclist versus car, multiple injuries, GCS of 8. The Glasgow Coma Scale is a measure of consciousness, with 15 being fully awake and alert, and 3 being completely unresponsive. And a GCS of 8 means this patient is severely altered, barely conscious, and likely has a significant brain injury. You designate another provider to handle the trauma because you're still managing the elderly woman with the subdural hematoma, and you can hear the chaos of the trauma resuscitation happening in the bay next to you, multiple voices calling out vital signs and injuries and orders. And it's just another day in the emergency department. Multiple critical patients simultaneously, all demanding immediate attention, and somehow you're supposed to manage it all without making any mistakes that could cost someone their life. 7 hours into your shift, the psychiatry consult service finally comes down to evaluate your suicidal patient. And after talking with her for about 20 minutes, the psychiatric resident agrees that she needs inpatient admission, which you already knew and told them 4 hours ago. but apparently they needed to do their own assessment to confirm, which is how the system works even when it's maddeningly inefficient. The problem is there still isn't a psychiatric bed available anywhere in the entire hospital system, so she's going to have to board in the ER probably for the next 2 or 3 days, taking up a bed and requiring continuous one-on-one observation by a patient sitter. And there are currently 6 other psychiatric patients already boarding in the ER, which means that 7 of your 28 beds, a full 25% of your department capacity, are being used for patients who aren't actually emergency patients anymore, but who have nowhere else to go. This is one of the most frustrating aspects of modern emergency medicine. You're not just treating acute emergencies, you're serving as the safety net for every failure in the healthcare system. Every shortage of resources, every gap in services, and you're expected to just absorb it all and keep functioning even though you're completely overwhelmed. A new patient in the waiting room is a 43-year-old woman with severe abdominal pain that started this morning. And when you examine her, her abdomen is exquisitely tender in the right upper quadrant, worse with deep palpation. And she's also got pain radiating to her right shoulder. And when you order an ultrasound of her abdomen, it shows multiple gallstones and a thickened gallbladder wall consistent with acute cholecystitis, meaning gallbladder inflammation. And she's going to need surgery to remove the gallbladder. You call the general surgery service, and they agree to admit her for cholecystectomy, but the surgery won't happen tonight because they're already doing 3 emergency cases and she's stable enough to wait until tomorrow. So she'll be admitted to a surgical floor and have the operation in the morning. Another patient, a 56-year-old homeless man with a chronic cough, has a chest x-ray that shows a large cavitary lesion in his right upper lobe, highly concerning for tuberculosis, and you need to place him in respiratory isolation immediately to prevent the potential spread of TB to other patients and staff, and you need to notify the public health department, and you need to order sputum samples for TB testing, and you need to start the process of arranging follow-up care for a man who has no address and no phone and no way to reliably contact him after he leaves the hospital. The complexity of treating homeless patients in the ER is something that's rarely discussed, but is a daily reality. They often have multiple untreated chronic conditions. They have difficulty accessing outpatient care. They can't afford medications. They can't follow up for appointments. And so they end up coming to the ER repeatedly for problems that could have been managed in a primary care setting if they had access to primary care, which they don't. So the emergency department becomes their primary care provider by default, which is both incredibly expensive for the healthcare system and incredibly inadequate for the patient's needs. You're trying to arrange homeless services and social work consultation and outpatient TB clinic follow-up, and the patient is just staring at you with this look that says he's been through this process before and knows that most of the resources you're trying to connect him with are going to fall through. And you feel helpless because you know he's probably right, that despite your best efforts, he's going to slip through the cracks in the system and end up back in the ER in a few weeks with his TB untreated and possibly having infected other people. 8 hours into your shift, and you're past the point of exhaustion into some strange altered state where you're functioning on autopilot, your brain somehow still processing information and making decisions despite the fact that your body is screaming for rest. A family approaches you at the nurse's station and they're angry, and They start yelling about how their father has been in the ER for 6 hours and hasn't been admitted yet, even though the doctor said he needed to go to the ICU. And you look up his chart and see that, yes, he does need ICU admission for severe pneumonia and respiratory failure, but there are no ICU beds available anywhere in the hospital. So he's boarding in the ER, getting the same level of care he would get in the ICU, but he's doing it in an ER bed with ER nurses who are also trying to care for their other patients. You try to explain this to the family, try to make them understand that you want to get their father upstairs just as badly as they want him to go upstairs, that the delay isn't because anyone doesn't care or isn't trying, it's because the entire hospital is full and there's literally nowhere to put him. But they don't want to hear your explanations. They want action. They want their father in an ICU bed now, and you understand their frustration, but there's nothing you can do except keep providing the best care you can in the ER while waiting for a bed to open up. The motorcyclist from the trauma earlier has been stabilized and is going to the OR for emergency surgery to repair his ruptured spleen and fractured pelvis. And the orthopedic surgeons are going to work on his multiple broken bones after the general surgeons fix the internal bleeding. And he's going to be in the hospital for weeks and probably months of rehabilitation. And you'll never know if he makes a full recovery or if he ends up with permanent disabilities, because again, that's just how emergency medicine works. You see people at their absolute worst moment, and then they disappear from your life. A woman comes in complaining of the worst headache of her life, sudden onset while she was at work. And those specific words, worst headache of my life, and sudden onset immediately make you think about subarachnoid hemorrhage, which is bleeding around the brain, usually from a ruptured aneurysm. And it's one of those diagnoses that you absolutely cannot miss, because if you send someone home with an undiagnosed subarachnoid hemorrhage, they're probably going to die. You order a CT scan of her brain, which is the first step in evaluating for subarachnoid hemorrhage, and it comes back negative, showing no obvious blood. But CT scans miss about 5% of subarachnoid hemorrhages, especially if they're done more than 6 hours after the headache started, which in this case it's been about 8 hours. So according to the standard of care, you need to do a lumbar puncture looking for red blood cells or xanthochromia, which is yellowing of the cerebrospinal fluid from breakdown of blood products, either of which would indicate bleeding around the brain, even if the CT didn't show it. You explain this to the patient, tell her you need to do a spinal tap, and she's terrified because she's heard that spinal taps are incredibly painful, which they can be, and you try to reassure her that you'll use plenty of local anesthetic and be as gentle as possible. But you also emphasize that this test is necessary to make sure she doesn't have a life-threatening bleed in her brain. The lumbar puncture is technically successful. You get clear cerebrospinal fluid, and when you send it to the lab for analysis, it shows no red blood cells and no xanthochromia, which essentially rules out subarachnoid hemorrhage. And you can safely tell this patient that her headache, while severe, is not from a brain bleed. It's probably a migraine or tension headache, and she can go home with pain medications and instructions to follow up with her primary care doctor. 9 hours into your shift, you're dealing with a patient who represents one of the most challenging aspects of emergency medicine. The person who comes in with vague, non-specific symptoms that could be anything from anxiety to a heart attack, and you have to figure out which it is using imperfect information and incomplete data. This patient is a 38-year-old woman named Sarah who's complaining of chest tightness and shortness of breath that's been going on for a few hours. And when you examine her, everything is normal, her vital signs are perfect, her oxygen saturation is 100% on room air, her lungs sound clear, her heart sounds are normal, her EKG shows no abnormalities whatsoever. But she's convinced something is seriously wrong. She's tearful and anxious, and she keeps saying, I just know something isn't right. And you're faced with the decision of whether to do an extensive cardiac workup with serial troponins and stress testing, which will take hours and cost thousands of dollars and will probably be completely negative, or whether to reassure her that her symptoms are likely anxiety related and send her home with instructions to follow up if symptoms worsen. The problem is that young women having heart attacks are notoriously difficult to diagnose because they often present with atypical symptoms and their risk factors aren't always obvious. And there are well-documented cases of women being dismissed as anxious when they were actually having cardiac events. And you don't want to be the doctor who misses a heart attack in a young woman because you assumed it was just anxiety. So you order the workup, the full cardiac panel, knowing that it's probably overkill but unable to take the risk of being wrong. And this is the defensive medicine that drives up healthcare costs and contributes to emergency department overcrowding. But it's also the reality of practicing in a litigious environment where missing a diagnosis can destroy your career. While you're waiting for Sarah's lab results, you get called to see a 5-year-old girl who's having a severe asthma attack. And when you get to her bedside, she's sitting upright and leaning forward, using every muscle in her chest and neck to try to breathe. And you can hear the wheezing from across the room, this high-pitched whistling sound with every breath. And when you listen to her lungs with your stethoscope, the wheezing is so loud and widespread that it's almost musical. Her oxygen saturation is 84%, despite being on supplemental oxygen. And she's tiring out using so much energy to breathe that she's starting to show signs of respiratory fatigue, which is terrifying in a child because once they tire out completely, they stop breathing and you have to intubate them and put them on a ventilator, which is a traumatic procedure in anyone, but especially in a small child. You order aggressive asthma treatment, continuous albuterol nebulizers, which means instead of the usual single dose, she's going to be breathing in the bronchodilator medication constantly for the next hour, IV steroids to reduce the inflammation in her airways, IV magnesium sulfate, which has bronchodilator properties and is used in severe asthma that's not responding to standard treatment. And you're preparing for the possibility that you might need to intubate her, calling respiratory therapy to bring the pediatric intubation equipment just in case. Because if her oxygen saturation doesn't improve in the next 15 minutes, you're going to have to make the call to secure her airway before she arrests. The mother is sitting beside her daughter, holding her hand, and you can see the absolute terror in her eyes. And you try to explain what you're doing and why, try to be reassuring while also being honest that this is a serious situation. And the mother asks, is my baby going to die? And you have to tell her that you're doing everything possible to prevent that. But yes, this is life-threatening. And you can see her face crumble as she processes that information. The albuterol starts working slowly but noticeably, and over the next 20 minutes, the little girl's oxygen saturation climbs from 84 to 88 to 91 to 95, and her breathing becomes less labored, the wheezing quiets down, and she's able to speak in short sentences instead of just gasping for air. And you feel that familiar flood of relief that comes when a critical patient stabilizes and you realize you're not going to have to intubate a 5-year-old today. She'll need to be admitted to the pediatric floor for continued treatment and monitoring, but she's out of immediate danger, and you've successfully managed another potentially fatal situation, which should feel like a victory, but mostly just feels like you've cleared one more item off an endless list of things that need your attention. Sarah's cardiac workup comes back completely normal, as you suspected it would, and you explain to her that her heart is fine, that what she's experiencing is likely anxiety or possibly a musculoskeletal chest pain. And you give her information about anxiety management and recommend follow-up with her primary care doctor and possibly a mental health professional. And she's relieved, but also seems slightly embarrassed, as if she wasted your time. And you try to reassure her that she did the right thing by coming in, that chest pain always needs to be evaluated, but you can tell she feels foolish. And this is the other side of the defensive medicine coin. Patients who turn out to be fine still had to go through hours of testing and stress and are left with a bill for thousands of dollars because we live in a system where it's safer to over-test than to miss something. 10 hours into your shift, and you're starting to make mistakes. Small ones so far, things like forgetting which patient you just saw or having to read the chart 3 times before the information actually registers in your exhausted brain. And this is when errors happen, when physicians are fatigued and overwhelmed and their cognitive function starts to deteriorate, but there's no option to stop and rest because the patients keep coming and they don't care that you're tired. A homeless man comes in with chest pain and his clothes are filthy and he smells of urine and alcohol. And you can see the nursing staff's barely concealed disgust, which bothers you because regardless of his social circumstances, he deserves the same quality of care as anyone else. But you also understand that healthcare workers are human and have their limits. And when you're dealing with challenging patients all day, every day, it's hard to maintain perfect compassion. His EKG shows ST segment elevations in the inferior leads, indicating an acute myocardial infarction, a heart attack. And despite his homelessness and alcoholism and poor hygiene, he needs the same life-saving treatment that you gave to David earlier in your shift. Thrombolytics or cardiac catheterization to open the blocked artery, aggressive medical management to prevent further damage, admission to the cardiac care unit for monitoring and treatment. You order the thrombolytics, explaining the risks and benefits, getting his consent, administering the medication, and arranging for cardiology to take him to the cath lab. And the whole time, you're acutely aware that after he recovers from this heart attack and gets discharged from the hospital, he's going to go right back to the streets. He's not going to be able to afford the medications he needs. He's not going to make his follow-up appointments. And he's probably going to be back in the ER in a few months with another cardiac event or some other complication of his untreated chronic diseases. And the cycle will continue because the emergency department can treat acute problems but can't fix the underlying social determinants of health that actually drive most disease. A nurse comes to find you with a concerned look that immediately puts you on alert, and she tells you that one of your patients, a woman who came in with abdominal pain and had been waiting in the hallway because there were no rooms available, just collapsed and is unresponsive, and you're running to her location, and when you get there, she's on the floor, not breathing, no pulse, and you're calling for help and starting CPR, and this is your third cardiac arrest of the shift. And you're so tired that your arms are shaking as you do compressions, but you push through because someone's life depends on it. The crash cart arrives. You get her on the monitor. She's in ventricular fibrillation. You shock her, give epinephrine, continue compressions, and you're going through the ACLS algorithm that's burned into your brain from years of training and practice. But part of your mind is also racing through the question of what caused this. Was this pulmonary embolism, a massive blood clot that traveled to her lungs and blocked blood flow? Was it a ruptured abdominal aortic aneurysm that caused her to bleed out internally? Was it a massive MI that you missed because she was waiting in the hallway and you hadn't gotten to her yet? The guilt is already creeping in. The self-doubt, the wondering if you could have prevented this, if you'd seen her sooner, if you'd prioritized her differently, if you'd somehow known that she was about to crash. You get her back after 6 minutes of CPR, restore a pulse, get her intubated and on a ventilator, and rush her to the CT scanner to figure out what caused the arrest. And the scan shows a massive saddle pulmonary embolism, a huge blood clot sitting right at the point where the pulmonary artery splits to supply both lungs, completely obstructing blood flow, and this is what caused her to arrest. And there was probably nothing you could have done differently because pulmonary embolisms are notoriously difficult to predict. And this woman didn't have any obvious risk factors or classic symptoms that would have made you suspect it. But knowing that intellectually doesn't stop the emotional response, doesn't prevent the second guessing and the replaying of events, wondering if you missed something. She needs thrombolytics for the pulmonary embolism, needs the clot dissolved immediately, but she just had CPR with multiple rib fractures, which means she's at high risk for bleeding, and thrombolytics could cause her to bleed into her chest or abdomen or brain. But without thrombolytics, the clot is going to kill her. So you're making another impossible decision, weighing the risks and benefits in real time, and you decide to give the thrombolytics because the certain death from the pulmonary embolism outweighs the possible death from bleeding complications. The medication goes in, she's transferred to the ICU, and you're left standing in the CT scanner room covered in sweat and feeling the crushing weight of responsibility that comes with making life and death decisions based on incomplete information and imperfect options. 11 hours into your shift, 1 more hour to go, and you're not sure you can make it, not sure you have anything left to give. But the waiting room still has 42 people in it, and the patient board is still full of red and yellow indicators showing overdue patients. So you drink some water and splash cold water on your face and force yourself to keep going. A teenager comes in with his parents complaining of testicular pain that started a few hours ago. And testicular pain in a young male is testicular torsion until proven otherwise, which is a surgical emergency where the testicle twists on its blood supply, and if you don't untwist it within 6 hours, the testicle dies from lack of blood flow. So you examine him quickly and order an ultrasound and page urology immediately, because this is time sensitive. The ultrasound confirms testicular torsion, showing absent blood flow to the affected testicle, and the urology resident arrives within 15 minutes, examines the patient, and agrees that he needs emergency surgery. And they're taking him to the OR immediately, because it's been about 4 hours since the pain started, which means there's still a chance to save the testicle if they operate quickly. Another small victory in a shift full of crises, catching a time-sensitive diagnosis and getting the patient to definitive treatment before permanent damage occurs. But there's no time to feel good about it because you've got a new patient, an 87-year-old man with dementia from a nursing home who pulled out his feeding tube and is now here for reinsertion. Except when you examine him, you find that he's covered in bruises in various stages of healing. He's malnourished despite supposedly being fed through the tube, and he has multiple pressure ulcers on his back and buttocks, which are signs of neglect, if not outright abuse. You're mandated by law to report suspected elder abuse, so you call Adult Protective Services and document everything meticulously, taking photographs of the injuries. But you also know from experience that these cases rarely result in any meaningful change, that the patient will probably go right back to the same nursing home because there's nowhere else for him to go. And the cycle of neglect will continue. The moral injury of emergency medicine is something that doesn't get discussed enough. It's not just the traumatic things you see. It's the systemic failures you witness every single day that you're powerless to fix. The patients who fall through gaps in the system, the social determinants of health that drive disease, but that you as a physician have no ability to address, the knowledge that you're providing Band-Aid solutions to problems that require systemic change. You're placing a new feeding tube in this elderly man, threading it through his nose and down into his stomach, and he's combative because of his dementia, doesn't understand what you're doing, and you have to hold him down while you complete the procedure. And it feels wrong, even though you know it's medically necessary. Feels like you're participating in a system that's causing harm rather than preventing it. The tube goes in, you confirm placement with an X-ray, and you arrange for him to be transported back to the nursing home, and you've done your job, but you feel dirty about it, complicit in a system that warehouses elderly people and provides inadequate care and makes money off their suffering. 12 hours now. Your shift is officially over, but there's a new patient in the trauma bay, a shooting victim, and the night shift doctor is still seeing patients in the other parts of the department and can't get to the trauma immediately, so you stay because that's what you do in emergency medicine. You don't leave until the critical patients are stabilized, even if your shift ended 20 minutes ago. The gunshot victim is a 23-year-old man shot twice in the abdomen at close range, and he's hypotensive and tachycardic, and his abdomen is rigid and distended, all signs of massive intra-abdominal bleeding, and you're calling for blood products and activating the massive transfusion protocol, which means the blood bank is going to send up coolers full of red blood cells and plasma and platelets because this patient is going to need massive amounts of blood replacement. The trauma surgery team is already on their way, and when they arrive, they take one look at the patient and decide he's too unstable to even go to the CT scanner. He needs to go directly to the OR. They're going to do an exploratory laparotomy and try to stop the bleeding surgically. And it's a race against time because he's losing blood faster than you can replace it. You help stabilize the gunshot victim enough to get him to the operating room, knowing that his survival is far from certain, but at least he has a chance now. And you finally hand off your remaining patients to the night shift and clock out. And you've been at work for 12 hours and 37 minutes. You walk out to your car in the parking garage, and the sun is setting, and you realize you went to work when it was dark, and you're leaving when it's getting dark again. And you've spent the entire day inside that fluorescent-lit emergency department without seeing natural light even once. Your body aches, your feet are throbbing, you have a headache from dehydration and lack of food, and you're so mentally exhausted that you have to sit in your car for 5 minutes before you feel capable of driving. You pull out your phone and see missed calls and texts from friends wondering if you want to get dinner or hang out, and you don't have the energy to explain why you can't, why the last thing you want to do right now is be around people and make conversation. So you just text back, work was crazy, need to sleep, and drive home in silence. At home, you can't eat even though you're hungry because your stomach is in knots from the stress and adrenaline. So you take a shower standing under the hot water for 20 minutes, trying to wash away the day. And when you close your eyes, you see the faces of your patients. Jennifer, the overdose, who may or may not have permanent brain damage. Michael, the construction worker with the pneumothorax, who was angry about the delays in his care. Lucas, the child with meningitis who might die or be left with disabilities. The teenager who was stabbed and covered in blood. The elderly woman with the subdural hematoma. The suicidal psychiatric patient who's going to board in the ER for days. The woman who arrested in the hallway while waiting to be seen. The gunshot victim who might be dying on the operating table right now. You lie in bed, but you can't sleep because your mind won't stop racing, replaying every decision you made, second-guessing yourself, wondering if you missed something or made a mistake that's going to result in a bad outcome. This is the reality that nobody tells you about when you're in medical school dreaming of being a doctor. The hypervigilance that follows you home, the inability to turn off your brain, the constant low-level anxiety that you missed something important, the dreams where patients are coding and you can't remember the ACLS algorithm, or you can't find the crash cart, or you're trying to intubate someone but the tube won't go in. Eventually, you fall into an uneasy sleep, and 6 hours later your alarm goes off because you have another 12-hour shift starting in 90 minutes, and you drag yourself out of bed feeling like you never rested at all, and the cycle begins again. This is emergency medicine, a relentless grind that demands everything you have and then demands more, that exposes you to the absolute worst moments of people's lives day after day, that requires you to make life and death decisions with imperfect information while being pulled in 20 different directions simultaneously, that leaves you physically exhausted and emotionally drained and perpetually second-guessing yourself. And here's the thing that really gets you. You knew it would be hard. Everyone told you it would be hard. But nobody could really explain what that hardness would feel like. The cumulative weight of all those decisions and all that suffering and all those systemic failures that you're powerless to fix. Nobody told you about the moral injury, the way your idealism would slowly erode as you realize that individual clinical excellence can't overcome systemic dysfunction, that saving one patient's life doesn't change the fact that the system is fundamentally broken and will continue to harm people. The burnout statistics for emergency physicians are staggering, and now you understand why. Somewhere between 40 and 60% of ER doctors report symptoms of burnout at any given time. Rates of depression and substance abuse are significantly higher than the general population, and emergency medicine has one of the highest suicide rates of any medical specialty. You've lost count of how many colleagues have left emergency medicine entirely, switching to less demanding specialties, or leaving clinical medicine altogether because the work is simply unsustainable long-term for many people. The emergency department administration keeps implementing wellness programs and resilience training as if the problem is that individual doctors aren't resilient enough, rather than the system itself being fundamentally designed in a way that causes burnout. They bring in speakers to teach mindfulness and stress management. They create wellness committees and encourage self-care. And all of this completely misses the point, because the problem isn't that doctors don't know how to manage stress. The problem is that the stress is objectively unmanageable given the working conditions. You're expected to see a new patient every single hour for 12 hours straight while simultaneously managing 20 plus other patients who are already in the department, make complex medical decisions with incomplete information and no margin for error, deal with an electronic medical record system that's clearly designed by people who have never actually practiced medicine, navigate a healthcare system that prioritizes billing and documentation over patient care, and somehow maintain perfect compassion and bedside manner with every single patient despite being exhausted and overwhelmed. And God forbid you make a mistake, because emergency medicine is one of the most litigious specialties, and if you miss a diagnosis or make an error in judgment, you're going to be sued. And even if you ultimately win the lawsuit, the process of defending yourself will take years and cause enormous stress, and you'll always wonder if you could have done something differently. The malpractice insurance premiums for emergency physicians reflect this risk, costing tens of thousands of dollars per year, money that comes out of your salary, which is good by normal standards but not particularly impressive when you factor in the 12 to 15 years of education and training required, the hundreds of thousands of dollars in student loan debt, and the physical and emotional toll of the work. You start to understand why some emergency physicians become cynical, why they order excessive tests to cover themselves legally rather than practicing evidence-based medicine, why they lose empathy for patients who come in with minor complaints when there are critically ill people who need attention. You fight against that cynicism. Try to remind yourself why you went into medicine in the first place, the genuine desire to help people and make a difference. But it's hard to maintain that idealism when you're drowning in bureaucracy and overwhelmed by patient volume and constantly being pulled away from actual patient care to deal with administrative tasks. The documentation requirements alone are crushing. Every patient encounter requires a detailed note that captures the history, physical exam, medical decision-making process, and treatment plan. And these notes have to be written in a specific format to satisfy billing requirements and legal standards. And they take forever to complete, and you end up spending almost as much time typing as you do actually seeing patients. And if your documentation isn't perfect, if you forget to check a box or use the wrong billing code or fail to document something that seems obvious from context, you might not get paid for the work you did, or worse, you might be accused of fraudulent billing and face legal consequences. The patient experience in the emergency department has deteriorated alongside the physician experience, because when the system is overwhelmed and dysfunctional, everyone suffers. Patients wait hours to be seen, sometimes spending their entire visit in a hallway because there are no actual rooms available, having intimate medical conversations within earshot of dozens of other people, getting tests and treatments in spaces that were never designed for patient care. The emergency department has become the safety net for every failure in the American healthcare system. Uninsured patients who can't afford primary care come to the ER because by law you have to treat them regardless of their ability to pay. Psychiatric patients in crisis come to the ER because there are no psychiatric emergency services and no available inpatient beds. Nursing home patients get sent to the ER for every minor change in condition because it's easier for the nursing home to transfer the problem than to manage it. Homeless individuals come to the ER seeking shelter from the cold or heat or just some human interaction. People with chronic pain come seeking medications. Patients with minor complaints come because they can't get a timely appointment with their primary care doctor, or because they don't have a primary care doctor at all. And mixed in with all of these are the people having actual emergencies, heart attacks and strokes and traumas and sepsis, and they all end up in the same overcrowded waiting room competing for the same limited resources. And it's impossible to provide good care to anyone when you're trying to care for everyone. The Centers for Medicare and Medicaid Services implemented a policy years ago requiring hospitals to report their emergency department wait times and patient satisfaction scores. And these metrics get tied to reimbursement, so hospitals are financially incentivized to minimize wait times and maximize satisfaction scores. But here's the problem. You can't rush medicine. You can't cut corners on the diagnostic process just to get patients in and out faster. And sometimes providing good medical care means telling patients things they don't want to hear or refusing to prescribe medications they're demanding, which hurts your satisfaction scores even though it's the right thing to do medically. So emergency physicians are caught in this impossible bind where they're being judged simultaneously on clinical outcomes, patient satisfaction, door-to-doctor time, length of stay, and a dozen other metrics that often conflict with each other. And meeting all of these standards simultaneously is essentially impossible. The business model of emergency medicine is fundamentally broken. By law, ERs have to provide medical screening and stabilization to everyone who comes through the door, regardless of ability to pay, which is ethically the right policy but creates an enormous financial burden for hospitals, especially those that serve low-income populations. Emergency departments lose money on most patient encounters, with the losses being subsidized by the profitable scheduled surgeries and procedures happening elsewhere in the hospital. But as profit margins get squeezed across healthcare, hospitals are reducing their subsidization of the ER, expecting emergency departments to somehow become profitable or at least break even, which is impossible given the mandate to treat everyone. So hospitals respond by cutting costs in the ER, reducing nursing staff, eliminating support positions, pressuring physicians to see more patients in less time, all of which degrades the quality of care and increases the burden on the remaining staff, which increases burnout, which causes more staff to leave, which makes the problem worse in a vicious cycle that has no obvious solution. The COVID-19 pandemic, which hit a few years ago, exposed and exacerbated all of these existing problems in emergency medicine, revealing just how fragile the system really is and how close to the breaking point emergency departments were operating even before a global health crisis. During the height of the pandemic, emergency departments were overwhelmed with sick patients, many requiring intensive care and ventilator support, while simultaneously dealing with shortages of personal protective equipment, testing supplies, medications, and most critically, staff. Healthcare workers got infected at high rates, forcing them to quarantine, which reduced staffing levels even further just when they were needed most. Emergency physicians and nurses were forced to make impossible triage decisions about who would get the limited number of ventilators, essentially choosing who lived and who died based on likelihood of survival, and those decisions caused profound moral injury that many healthcare workers are still processing years later. The pandemic also revealed the degree to which public health failures create emergency department problems. The lack of adequate primary care infrastructure meant that people who should have been treated early in an outpatient setting ended up in the ER severely ill. The politicization of basic public health measures like masking and vaccination meant that preventable cases kept flooding emergency departments long after we had the tools to control the pandemic. And the complete inadequacy of mental health services meant that the secondary mental health crisis caused by the pandemic with surging rates of depression, anxiety, substance abuse, and suicidal ideation, all landed on emergency departments that were already completely overwhelmed. Many emergency physicians who might have stayed in the field for decades left during or immediately after the pandemic, deciding that the personal cost was simply too high, that no amount of money or professional satisfaction was worth the trauma they were experiencing. And the workforce shortage in emergency medicine has gone from concerning to critical in many parts of the country. Some emergency departments have closed entirely, unable to staff themselves, which means the remaining ERs in the area have to absorb even more patient volume, making an already impossible situation worse. The staffing crisis has led to increased reliance on locum tenens physicians, temporary doctors who travel from hospital to hospital filling gaps, which provides bodies but undermines continuity of care and institutional knowledge. And frankly, many locums are physicians who couldn't maintain permanent positions for various reasons, so you're not always getting the highest quality care. Some emergency departments have turned to mid-level providers, nurse practitioners, and physician assistants to help with the patient volume, but there's ongoing debate about the appropriate scope of practice and level of supervision required, with some evidence suggesting that unsupervised mid-level care in emergency settings leads to higher rates of unnecessary testing, inappropriate admissions, and misdiagnoses. The American healthcare system is the most expensive in the world by far, spending nearly twice as much per capita as other developed nations. But outcomes in emergency care are often worse than countries that spend far less, because the money isn't being spent efficiently. It's being siphoned off by administrative overhead and insurance company profits and a billing system so complex that hospitals have to employ armies of people just to navigate it. You start to realize that lasting even one day as an ER doctor isn't really about whether you can handle the medicine, whether you know enough pathophysiology or can perform the procedures or can manage the acute crises. Because honestly, the clinical medicine is the easy part, the part you were trained for, the part that makes sense. The hard part is everything else: the systemic dysfunction, the impossible patient volumes, the inadequate resources, the constant interruptions, the electronic medical record system that fights you at every step, the consultants who don't respond, the lack of inpatient beds causing patients to board in the ER, the administration pressuring you to see patients faster while simultaneously demanding more documentation, the malpractice anxiety, the hostile patients who view you as an obstacle rather than an advocate, the moral injury of being complicit in a system that you know is failing people. The hard part is maintaining your humanity and compassion when you're seeing 30 or 40 patients per shift, each with their own complex needs and suffering, and knowing that you can't possibly give them all the time and attention they deserve, that you're constantly having to triage not just who to see first, but who to actually invest your limited emotional energy in. The hard part is going home after a shift where you've seen child abuse and domestic violence and drug overdoses and gunshot victims and people dying of preventable diseases because they couldn't afford health care, and then being expected to just decompress and be normal and have relationships and hobbies and a life outside of work, as if you can just turn off the part of your brain that processes trauma. The hard part is the slow accumulation of all those experiences, all those patients, all those decisions, all those losses, building up over months and years until you realize that you're not the same person you were when you started, that something fundamental has changed in you, that you've seen too much suffering and absorbed too much stress and made too many impossible choices. And you can feel yourself becoming harder, more cynical, less empathetic, and you don't like what you're becoming, but you don't know how to stop it. The hard part is the realization that individual excellence and dedication and compassion aren't enough, that you can be the best doctor in the world and still have patients suffer because the system is broken in ways that you personally can't fix. The hard part is accepting that emergency medicine is a young person's specialty, that very few physicians make it to retirement age still working clinically in emergency departments, that at some point you're probably going to have to transition to something else, urgent care or occupational medicine or hospital administration or something completely outside of medicine, because the physical and emotional demands of emergency medicine are simply not sustainable long term for most human beings. And yet people keep going into emergency medicine, keep choosing this specialty despite everything, because there's something uniquely meaningful about being the person who's there when people are having the worst day of their lives, about having the knowledge and skills to save lives, about the intellectual challenge of diagnostic dilemmas and the adrenaline rush of managing critical patients and the camaraderie that develops among people who work in high-stress environments together. There's something that keeps you coming back despite everything. Some combination of professional pride and genuine desire to help people, and frankly the addictive nature of the adrenaline and the constant novelty and the feeling of being needed, of knowing that what you do actually matters even if the system is broken. So could you survive even one day as an ER doctor? The honest answer is maybe. Physically, you could probably make it through a single 12-hour shift. You could see the patients and order the tests and manage the acute crises, especially with experienced nurses and other staff supporting you. But surviving one shift isn't really the question, is it? The question is, could you do this day after day, week after week, year after year? Could you sustain this level of intensity and stress and responsibility without burning out or making a catastrophic error or losing your sense of self? Could you maintain your empathy and compassion when you're seeing the same problems over and over, when you're dealing with hostile patients and system failures and impossible demands? Could you handle the weight of knowing that your decisions directly determine whether people live or die, and that even when you do everything right, patients still sometimes die, and you have to process that and move on to the next patient without time to grieve or decompress? Could you cope with the reality that emergency medicine isn't like it looks on television, isn't dramatic rescues and triumphant moments and grateful patients,
but is mostly grinding through an overwhelming patient load while dealing with bureaucratic obstacles and trying not to miss the rare, truly critical case hidden among dozens of minor complaints?
Could you accept that the healthcare system is broken in fundamental ways that you personally cannot fix, that you're going to see the same patients over and over trapped in cycles of poverty and addiction and mental illness and homelessness, and that the Band-Aid solutions you can provide in the emergency department aren't addressing the root causes? The reality is that most people couldn't last even one day. Not really. Not if they understood going into it what they were actually signing up for. Not if they felt the full weight of that responsibility and that stress and that moral injury. And the people who can last, who do make it through day after day and year after year, they pay a price for it in their physical health and their mental health and their relationships and their sense of who they are as people. Emergency medicine has one of the highest divorce rates of any profession, because it's almost impossible to maintain a healthy relationship when you're working night shifts and weekends and holidays, when you come home emotionally and physically exhausted, when you're too drained to be present for your partner or your children, when you're irritable and withdrawn because you're processing trauma that you can't talk about due to patient confidentiality. So, yeah, you probably wouldn't last a day as an ER doctor, but here's the thing. Most ER doctors wouldn't last a day doing whatever it is you do, because everyone has their own challenges and stress and skills that they've developed. The difference is that ER doctors are dealing with life and death. Stakes, making decisions that have permanent, irreversible consequences, absorbing other people's trauma and suffering as part of their job description, and doing it all within a system that's fundamentally broken and seems designed to make their jobs as difficult as possible. And if this entire script has made you feel uncomfortable or anxious or grateful that you don't have to do this job, well, that was kind of the point, because emergency medicine is essential to society. We need people willing to do this work, but we should also acknowledge and appreciate just how difficult it is and how much we're asking of the people who choose this career. And maybe, just maybe, we should work on fixing some of the systemic problems that make it unnecessarily harder than it needs to be.